Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. All right, thanks for tuning in to episode 17 of the Super High Yield Anesthesia Podcast. And today we'll talk about a bunch of anesthesia considerations for OB procedures, specifically tubal placental removal as well as uterine inversion. And lastly, we're going to talk about cerclages. So basically, the idea is try to, in addition to the episode on C-sections previously, to give you, the anesthesia considerations for the most common procedures that you'll see when you're doing your OB rotation. So without further ado, let's go ahead and get started. So the first thing we're going to talk about is the considerations for postpartum tubals, placenta removal, and uterine inversion. So basically, these following considerations would be applicable to these three things. So first of all, we're going to talk about the surgical considerations and then move on to the actual anesthesia stuff. So regarding surgical considerations, positioning, basically patient's just going to be in a supine position, possibly in a T-Berg or Trendelenburg position. Regarding the incision, usually it's going to be infra-umbilical. And the unique consideration about this is, especially when you're doing a postpartum tubal, there's like a special consent form for sterilization. And I think in our hospital and I think our state, we have to wait a certain amount of time. I believe it's a full 24 hours or something like that for them to provide consent. It's just giving them time to actually consider it before we actually do the sterilization technique. Even though technically a tubal could be reversed, it's still something that they have to consider. Okay, regarding antibiotics, they are none. So these procedures don't require any antibiotic prophylaxis. The surgical time depends on the surgeon, but it usually is relatively quick. So within 15 to 25 minutes, EBL is going to be very minimal. So usually around 10 cc's. And it's not too painful of a procedure as well. So the pain score is going to be around 3. Okay, so let's go ahead and move on to our fun stuff, the anesthesia considerations. So regarding pre-op, first we're going to talk about timing, and then we're going to move on to talking about the system-specific pre-operative considerations. So regarding timing, usually it's convenient for everyone involved to do it at the same time as a C-section. So if you're doing a postpartum tubal, you're going to usually do the C-section first, and then you do the tubal right after. But some OB doctors like to prefer waiting 8 to 24 hours afterwards. So basically do the C-section, and after that certain amount of time, they come back and do the tubal ligation. Mainly, they just want to see any significant postpartum complications before they move on to doing the tubal ligation. Regarding epidurals, like if the patient had an epidural for the C-section and you're planning to using that for the tubal ligation, basically it does have a expiration date essentially. So basically within 24 hours of delivery, the successful reactivation rate is about greater than 92%. But after 24 hours, the successful reactivation rate drops to less than 80%. So the faster and earlier you use the epidural as following the C-section, the more likely you have success. And also regarding the waiting period, if they end up waiting 24 hours after the C-section to do the tubal ligation, you technically could do general anesthesia with like reduced risk for aspiration, mainly because the GI-related changes in pregnancy generally resolves after the first 24 hours, so GA wouldn't be a bad idea for this procedure. So that's regarding timing. Let's move on to talking about the systems-based considerations. So first, respiratory. Basically, the FRC that is usually decreased in pregnancy, it resolves and turns to normal almost immediately after delivery. But the problem is there is still laryngeal edema. So you're still going to use a smaller ET tube if you decide to intubate. Okay. Next is cardiovascular. Again, after delivery, the aortal cable compression resolves immediately after delivery because you don't have a giant baby pushing onto the vessels anymore. So that resolves. But one thing to keep in mind is right after delivery, that's when the patient would have the maximum cardiac output. Because again, remember, after baby is delivered, all that blood that was in the placenta enters the maternal central circulation. So you're basically getting a huge blood bolus. So that's why you have increased cardiac output immediately, or the maximum cardiac output immediately after delivery. Generally, this returns to normal about days to weeks after delivering the baby. Okay, next is GI stuff. So if the tubal ligation is scheduled within 8 hours of the C-section, the patient still needs to be NPO because there's still the risk for aspiration. But if you wait after the 24 hours, the risk for the aspiration decreases, but they should still be NPO before the procedure. Okay, next is neurological considerations. Basically, for pregnant patients, the local anesthetic requirement for spinals and epidurals are actually decreased compared to non-pregnant patients for about 36 to 48 hours after delivery. Labs are basically by history and physical, and for pre-medication-wise, consider giving sodium citrate, or the brand name is Bicitra. Okay, next, the intraoperative considerations. Regarding technique, spinal anesthesia is preferred if the epidural is not in place. General anesthesia is acceptable if the patient has a strong preference for doing GA or there's a contraindication to neuroaxial. Because remember, one of the absolute contraindications to doing neuroaxial procedures is patient refusal. So super important, and that's actually one of the Q-bank questions. So definitely keep that in mind for not only clinical practice, but board relevant stuff as well. Okay. Regarding regional, again, we have spinal or epidural. For spinals, you generally would use hyperbaric bupivacaine as well as fentanyl, or in some places, you can use Precedex in addition to the bupivacaine. But either way, your goal for the block is to go up to T6. So the level of T6 for the spinal. Okay, next is the epidural. Basically, the ideal situation is you give a 3 cc test dose again, just to making sure that the epidural is working okay, with making sure there's not intravascular or intrathecal or anything like that. And then from there, you kind of load the epidural with 2% lidocaine, make sure it's preservative free. Generally, you can give 15 to 20 cc's. At my institution, we pretty much have a 20 cc syringe, fill the syringe with 18 cc's of the 2% lidocaine, and you give 2 cc's of bicarb. So basically, by alkalinizing the solution, it helps the solution work a little bit faster. So that's what we do. The other options using 3% chloroprocaine, you're kind of just, you're either, if you're using chloroprocaine or the lidocaine, the idea is to inject it incrementally. So you're not injecting the entire syringe at once. You're giving, what I do is I give 5 cc's at a time and just check levels and see how the patient does. Then give 5 cc's and keep going from there. And you can also consider giving some either morphine or fentanyl through the epidural as well. Okay, so that's regional, which is like the preferred method. But again, you could do general anesthesia. Regarding induction, you still going to consider doing RSI, so rapid sequence induction or propofol and succinylcholine with the ET tube, especially if it's within 24 hours of the delivery. But if it's greater than 24 hours since the delivery, it's possible to use the LMA. Okay, maintenance is standard. Emergence, you're going to do an awake extubation. For blood and fluid, usually, as we mentioned earlier, the EBL is going to be very minimal. So not necessarily too concerned about hemorrhage risk. IV-wise, it's ideally to have at least one 18 gauge or higher. Monitoring is going to be standard. And again, positioning is going to be supine. All right, and for postoperative, the main thing you're going to be considering is pain. So one thing you can do is using neuroaxial opioids. So if you're doing the spinal, you can inject some fentanyl intrathecally, about 10 to 20 mics. Or if you're doing it through the epidural, you can do 50 to 100 mics through the epidural. And this is usually done intraoperatively, then over to the postoperative period. Other than that, you can give them oral opioids. Generally speaking, I like to just use fentanyl for these patients, mainly because there's less risk of it to transfer to the breast milk, because likely these patients will be breastfeeding. So using fentanyl is a good idea versus using oxycodone and Dilaudid, which kind of has the risk of entering the breast milk. And lastly, since the patient delivered the baby, then you could consider using NSAIDs, which would have been a contraindication due to the teratogenicity. Okay, so we're halfway through. So that was the anesthesia considerations for postpartum tubals, as well as placenta removal and uterine inversion. So next and last, we're going to use cerclage placement, both the elective and emergent situations. And what a cerclage is basically a reinforcement of the cervix to basically prevent early dilation of the cervix. Regarding surgical considerations, for elective cerclages, it's usually done in the first trimester of pregnancy, so approximately 14 to 16 weeks. And these patients generally have a history of cervical incontinence. And if we're doing it emergently, this is usually done during the second trimester, but it's not performed if it's advanced cervical dilation. So we don't necessarily need to know this part, but there's two types of cerclages. So there's a McDonald one and a Schurter-Carr. I don't know. Again, not too important for us, but there's those two types. Regarding positioning, it's a dorsal lithotomy usually. Antibiotics is not indicated for this case. For regarding surgical time, it's about half an hour to 1 hour, and EBL is going to be minimal as well, so around 25 to 30 cc's. All right, next is intraoperative, and we're going to first talk about some unique considerations for this stage of pregnancy, because again, we're now considering the baby as well. Because remember, when we're doing C-sections or postpartum tubals, like the baby's out, so we can just focus on doing considerations for the mother. But now, for cerclages, baby is still in there. So we're going to have to definitely keep in mind about our drugs and how it's going to affect the fetus. So important thing to know is organogenesis occurs within the 15 to 56 days in the pregnancy. So during this stage, the drugs should be minimized if possible. But the interesting thing is that there's no conclusive evidence of teratogenicity in humans, and that's including nitrous oxide. For, ethical purposes, there haven't been real studies that's ethical that can prove it conclusively that, that's in the ethical manner. So, but in animal models, like you should just, be concerned for minimizing the amount of drugs you use. Other unique considerations basically try to maintain a normal blood pressure to ensure that there's adequate uteroplacental perfusion and fetal oxygenation. If the pregnancy is greater than 20 weeks gestation, definitely do a left lateral displacement to avoid aortocaval compression. For these procedures, also have fetal heart monitoring. And lastly, the type of technique we use. Neuraxial is the preferred method for cerclages. Spinal anesthesia is the ideal route, and epidural is a good alternative. So speaking of which, regarding technique, regional, as we said, spinal is preferred, as we said. And generally for the spinal, so you're going to use pretty much the same exact concoction as for every other OB case. So hyperbaric bupivacaine, 0.75% with fentanyl if you like pain control for postoperative pain. And the goal for cerclages is going to be T8 to T10. So again, this one's going to be a little bit lower as opposed to our goal for the tubal ligation, which is going to be T6. All right, so again, for cerclages the goal is to block up to T8 to T10. And for the tubals, it's going to be up to T6. For GA, pretty much the same considerations as for the tubal ligation. Induction, you're going to do RSI or propofol and sucks. Use the ET tube. Maintenance is going to be standard. Emergence is going to be awake. Blood and fluid is going to be minimal EBL, but at least have a working 18 gauge. Monitoring is going to be standard, and positioning, as we said, is going to be a dorsal lithotomy. So just be sure to make sure that the legs are padded and try to make sure the patient doesn't move too much during the procedure to avoid any nerve damage. Okay, lastly, we're going to talk about the postoperative side. So complications, one is the preterm labor. So definitely observe them in the recovery area. And if they need to give some tocolytics, and this one is most likely just going to be done by the OB team, but it's something to be aware of as well. Other complications, especially if they had neuroaxial anesthesia, is hypotension. So definitely treat that. And again, peroneal nerve injury regarding positioning. So this generally presents with foot drop and loss of sensation, specifically in like the lateral side of the lower extremity. And this is actually a pretty important board question that's relatively easy as well. So again, peroneal nerve injury generally presents with foot drop and loss of sensation. Lastly, pain management. If you did a spinal, you could give opioids during the injection. So fentanyl, 10 to 20 mics is good for these cases. Otherwise, you can give some IV opioids, or if you're going to give oral analgesics, try to avoid NSAIDs because, again, during pregnancy, they have teratogenic effects, or you can give Tylenol as well. Okay, that's it for this episode. Hopefully that was helpful to you. So that said, the fun fact I have for you today is from kidsactivitiesblog.com, and it says kangaroos can't walk backwards. All right. Again, thanks for listening. This is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.